everyone. Welcome to the No Normal Show for Thursday, November 12th, brought to you by ReviveHealth. This is our weekly deep dive into how hospital and health system marketers can navigate what we call the no normal. I'm Jeff Spear, your guest host for the week. As always, I'm joined by Chase Kleckner, Senior Marketing Manager at ReviveHealth and our show producer. Hey, Chase.
Hey, Jeff. Good to see you. Welcome back.
Thank you. Good to be back. It's been a while. And today we're also joined by our CEO, ReviveHealth CEO and founder, Brandon Edwards. Brandon brings, as you all know by now, 27 years of experience in healthcare and integrated marketing, and really lots of expertise in issues management and complexities inherent in the business of healthcare. Hey, Brandon.
Hello.
My first time getting the privilege of hosting you.
We'll see about that.
Okay. All right. We got a lot to talk about today, but some quick notes before we dive in. As you know by now, the podcast will be sharing some industry trends, research, and stories from those within and outside the industry. And if you want to understand more about what we mean by the no normal key principles, check out our blog post, which Chase is going to share in the chat function if you're joining us live. Also on our website, of course, at thinkrevivehealth.com/COVID-19 for that if you're listening to a recording of the show. For our live listeners, please use the question queue in Zoom to line up your questions, and we'll get to as many of them as possible. You can also use the chat function to talk to the attendees. But if you got a question for Brandon or I or Chase, please use the question queue only. We'll also provide some links to some news we're going to talk about today in the chat function. For anybody else who's listening, remember you can subscribe on the podcast on iTunes or wherever you listen to podcasts. And we've got plenty and lots of content supporting things that we'll probably reference in the show today, as well as previous episodes of the podcast on our website. Okay, let's get into things a little bit here. A couple updates and news from the day. As many of you are probably listening, again, it's Thursday, November 12th. We know that coronavirus cases are spiking yet again. In fact, cases last week were about 104,000, and now we've got 145,000 on Wednesday. So it's an all-time high. A couple kind of disturbing quotes, I think. Disturbing in terms of things we need to be thinking about. Dave Dillon, spokesman for Missouri Hospital Association, where they're seeing a huge surge, says, "We're at a fairly critical juncture. The day will soon come when hospital staffing will fall below standards that are normally required." So he says that publicly. It's published. And somebody from Yale School of Public Health, an infectious disease physician, says, "We're having widespread transmission. It's going to get worse, certainly for the next month." I know our comms and marketers and other health system leaders right now listening are thinking about this, but I just think quickly we need to talk about the implications before we get into some other stuff that we want to talk about today, including the election and some implications of that. So Brandon, you hear that. You've been talking to some hospital associations across the country. What do you think about that? What is the discussion out there?
Yeah, I think there's sort of three concerns, and I would say maybe in this order of importance, right? The first is obviously the human impact, right? That the estimates I've seen, because hospitalizations trail diagnoses, deaths trail hospitalizations. We're saying by the end of January we could be seeing 2,000 to 2,500 deaths a day in the United States, which is terrifying, really, when you think about the numbers. Now, those are models and projections, and I know people that aren't enthusiastic talking about COVID will dismiss some of those, but I think we can all agree that more than one is too many, right? And that's something we have to deal with. So that's sort of issue one, is just dealing with the human toll and the toll that takes on caregivers as well, right? We saw that in New York, and we saw that in some other markets that, where caregivers are just exposed to patients that they can't help very much day after day after day. It does take a toll, and it eventually takes a health toll on them as well. I think second is the concern that the surge will continue to erode volumes in elective surgeries, right? So that preventative care, elective procedures, that, even absent a shutdown, a pause in those things, that typically providers see a surge in volume in Q4. That seems extremely unlikely this year. The latest data shows that year over year volumes on inpatient surgical procedures are down 18.6% year over year from last year. And some of them, particularly high margin services like hips and knees and those kinds of things, are down 30, 40, 50%. So, that I think there's a rightful worry that people are going to avoid care that they need, whether that's preventative care like mammograms and colonoscopies and immunizations, all the way through to elective surgical procedures that help people get out of pain or help them be well again. And then the third, I think, would be the worry of codifying that, right? That when we see states requiring shutdowns or cities requiring shutdowns in certain markets, because if the MHA guy is right, then the idea that we can't safely staff a hospital means the responsible thing is to not be bringing in patients that don't absolutely have to be there. And yet that also pays a price, right? That whether that's, heart attacks and strokes and all of those things. So, I mean, I think there's a lot to worry about. And sometimes as marketers, I think we can feel a little helpless in that, but I don't think we should. Like we have a huge role to play in communicating with people and educating them and reassuring them and getting them to wear a freaking mask, whatever it is. There's a lot of things that we can help with, I think.
Yeah, I agree. I think if they haven't already done it, our listeners, if you haven't already done it, you've got to really go back to where we were in the spring and bring back that comms plan and the cadence of meeting with your team, really working with state officials, public health departments, and unfortunately, if you don't have one, getting a plan on how you communicate if you have to adjust your care protocols because you don't have capacity. And that's not anything anyone wants to be thinking about, but you've got to deal with that. And you also have to deal with your comms plan and your engagement plan, the community plan for the vaccine all at the same time. There's plenty to be done, but we're certainly not through it. Kind of moving on to equally maybe not fun topic, but for different reasons, also came out that the insurance, our friends in the insurance business, will owe a massive MLR rebate next year. On Modern Healthcare, they reported that more than 11.2 million people will qualify for nearly $2.5 billion in medical loss ratio rebates. That's up from over $1 billion last year. In fact, so that's 150% of that. This is one of those things that it qualifies to about $219 per person. So in that regard, I don't think any individual is going to feel a whole lot of relief. But clearly, there's some implications here that we're going to talk more about later. But Brandon, just what's your first take on that, and what should health systems, if anything, be thinking about?
Yeah, and be fair, I'm not an expert in the rebate provisions of the ACA, but as I understand it, it's not quite that simple. I believe that there's a calculation that takes into account more than one calendar year period. There are, also, let's just be honest, there are different ways payers could have avoided this, right? There's, one, they could have actually paid providers. God forbid we pay providers during a time when they're losing hundreds of billions of dollars in revenue on extremely thin margins. And in fact, the health plan industry has reacted quite the opposite of that. They've actually upped the aggression in contract terminations, and denying pre-auths and denying payments and all kinds of things. So that would have helped to avoid it. Two, and I think is much more likely, is premium holidays for employers as opposed to rebates to consumers. I think it seems fairly clear that health plans have no interest in stepping into the void created for providers, or doing anything really to alleviate pain for consumers, other than some very limited term things like, telehealth and that kind of stuff. Not to minimize it, it's important, but it's not save the world important. Where they seem to be clearly putting their money is on the employer side. So we've seen that some already with some employer premium holidays. I think that's much more likely, right? So you're effectively rebating, if you will. You're just rebating to the employer, not to the end consumer in that. And I think to the extent that those will be required, that's probably much more likely, much more ubiquitous strategy that we'll see. I think, if you're a betting person, you bet that there's going to be very little money that flows to consumers from the health plans. Like that's that's a safe bet in Vegas.
But we'll save a little more of that for a little bit later. But I do want to get into what this means in the overall context of what health systems are going through, and what key constituents like employers and consumers, what they see and don't see when these two very disparate things are happening at the same time. Third news item before we get into the bulk of our content: Michigan Blues and Premise Health announced an agreement that Blue Cross Blue Shield Michigan will begin offering wellness center benefits to employer-sponsored health plans as part of a partnership with Premise Health. So basically, Premise Health provides on-site wellness clinics. This maybe seems like something from the early 2000s when on-site clinics were kind of a big deal, but I think it's different now because we're seeing a big movement, and I've got some consumer data I can talk about later, to more interest in wellness and less, I would say, preference and loyalty to who provides it from consumers. And we know, of course, that the insurance company is venturing hard into our territory here. Brandon, anything else you want to comment on that, and kind of what, if anything, our health systems need to be thinking about in this area?
Yeah, I actually think, first of all, I think Premise is a great company. They're headquartered here in Nashville. They do a really good job. I'm not at all surprised to see partnership on the payer side, right? That selling to employers is hard. Selling to health plans is hard, but when you get them, you get a lot of opportunity that comes out of it. And I think, to your point, this fits right into the trend we're seeing, where payers are increasingly becoming providers in particularly those more top of the funnel services, urgent care, primary care, all of the things that will lead to steerage for more acute services, elective services, lab, radiology, pharmacy, all of those things that when you're at the top of the funnel, you get to play a bigger role in directing that. So not surprised. I mean, I think it'll be interesting to see how that's branded and marketed, because consumers are pretty vocal that the idea of having healthcare provided by their health plan doesn't feel good to them. That they like the separation of church and state in that. But we'll have to watch it. Like I think it feels like a smart move for Premise and maybe not a great thing for providers.
Yeah. Okay. Let's talk a little bit about a little election that we had, what seems like 17 weeks ago, but I think it was only about 10 days ago. I
feel like when we talk about the election, we need a hug, right? Everybody needs a hug.
Yeah. Virtual hugs all around. Well, at this point, what we all know is Biden is the president-elect. There's a lot of lawsuits happening, and there will likely be a narrowly Republican Senate, though that will be decided in January at this point. It could be 50-50 with the Vice President Harris being the tiebreaker, and we've got a Democratic House. So, Brandon, we all, I'm sure, have been following the election and really interested in hearing what you feel the implications are for healthcare providers.
Yeah, I mean, I do think it's definitely, if you're a political junkie, it's definitely interesting to watch, right? If you're just a citizen, it's probably terrifying in a lot of ways. But if you view politics as sport, this is pretty fascinating. I mean, I think to your point, look, Biden's going to be president. I mean, there's statistically, the margin of victory in this election is much wider than Trump's margin of victory was in 2016. The popular votes, over 5 million votes in Biden's favor. Not that ultimately matters, but at this point, about the only thing that stops this is faithless electors at the Electoral College, which there's really not any precedent for in the modern era. So, again, barring something really unusual happening at this point, Biden's going to be president. House is narrowly Democratic and has become narrower. And the Senate, to your point, will either be 50-50 with Vice President Harris, breaking the tie, or narrowly Republican, which is probably more statistically more likely. And Georgia sends Republican, Senate, basically. Though God knows, it could be anything this year. And with Trump not on the ballot, it could be a different outcome for sure. So what does that mean? The other that's fascinating just came out today. Apparently, Trump is about to announce, at least internally, that he plans to pardon himself before he leaves office, which
Can you do that?
Apparently, it's at least possible. I think that's also an interesting conversation. Pardon from what, one might ask, but perhaps also a topic for another day. So what does this mean? I think, right? If you're a fan of stimulus, Biden leaks indicate $2.2 to $2.4 trillion stimulus would come out of a Biden administration. If the Senate really is narrowly Republican, I don't think it's 2.2 or 2.4 trillion. Although McConnell has said very clearly there will be stimulus before January. I think rightly so. He's now thinking about the 2022 midterms with a very narrow Republican Senate. So you have that to deal with. I think it's very likely that you end up with a Biden administration antitrust posture that's more similar to what we saw in Obama than what we've seen in Trump, in a Trump interpretation of that, or candidly in what we saw in sort of legacy Republican antitrust posture. Trump's antitrust posture is not Republican, it's Trump, and so it has a different flavor and a different attitude about it. And so I think those are probably the big things. I also think, at least based on everybody we've talked to, the idea that the ACA is going to be overturned by the Supreme Court seems very, very unlikely after the hearing. Like it would have been hard for the hearing to go worse for the plaintiffs, at least according to the media coverage and the court watchers experts.
Yeah, the oral arguments, I think Roberts and Kavanaugh were both pretty, at least in what they said, seemed to question the validity of the challenge and the intent of, or I should say the harm of not having an individual mandate, and who's getting harmed by that, and really is that enough to break the whole thing down? Let's go back real quick, and then I want to come to the ACA, but on the stimulus, so we've got possibly, I think, the number that McConnell and the Republicans are comfortable with publicly is around 550 billion compared to the 2.4 trillion. That's a big gap. And we just talked in the opening about the potential financial devastation continue that hospitals and health systems are facing. What does that mean for us if we bring those two things together for marketers?
Yeah, I mean, I think ultimately, let's just assume any stimulus is good stimulus, whether it flows directly to hospitals or whether it flows to consumers who then have money for discretionary spending. Both of those are going to be helpful. Let's also assume that any stimulus, just like the first and second rounds, are not going to close the gap for hospitals. So I think ultimately the message for marketers and hospital executives is, the Lord helps those who help themselves. And stimulus is not going to save us from a terrible financial year.
Yep.
We're going to save ourselves. Now, thank God the market's up. That certainly helps with non-operating income. Many hospitals and health systems are very reliant on that to stay solvent. But I don't really know whether to take any of these numbers seriously. Like the 2.4 trillion felt like a Nancy Pelosi number, and the 500 billion felt like a Mitch McConnell number. And the truth, like most things, probably lies somewhere in between. But I think either way, you have to look at it as anything's good, but it's not going to solve the problem. It's going to be a sort of a partial solution, I think it seems most likely.
Yeah. So going back to the ACA now, if it's not struck down, maybe things just continue on since that. What do you think? The other discussion that we've seen in the last couple of days related to, I guess, coverage is Biden has publicly said they want to lower the Medicare eligibility to 60. He's put that out there. We know there's some major financial implications if that could actually happen for our hospitals and health systems. Just talk a little bit about, I guess, a couple scenarios for the next couple of years before midterms, if we continue with what we discussed earlier in terms of divided government.
Yeah, and I think it is a reasonable assumption it stays in place. Also, let's be honest, if they overturn it, who knows, right? I think the idea that insurers may want to keep 26 as the number for dependence on insurance and stuff like that seems likely. They like the enrollment. It's generally not a sick cohort, right? There's a lot of reasons that some aspects might remain in that. I also think it's perfectly reasonable to assume that whatever stays in effect will be good for health plans. It may or may not be good for hospitals, but it'll be good for health plans. That's one thing that's a sure bet, I think. I think it's really interesting. I've been watching the enrollment data between commercial Medicare and Medicaid. Medicare's up fairly dramatically. In fact, Humana just announced earnings. They showed a 10% year-over-year increase in MA enrollment. Again, not surprising, right? Aging in is a real thing. Medicaid is up, but not as much as we might think. And commercial is not down as much as we might think. Commercial declines for the nationals was sort of less than 2% down. Medicaid enrollments were up sort of mid-single digits. So it doesn't seem that people are going from commercial to uninsured. They're going from commercial to Medicaid, or Medicaid, particularly expansion into red states that were initially reticent, does seem to be picking up uninsured, which is, after all, what the law was supposed to accomplish in the first place. So I think we will, I don't think that coverage losses are going to be as significant out of this recession as we feared because of more furloughs than layoffs. I think that will shift mostly to Medicaid. Now, you lower the retirement age for 65 to 60, there are fairly significant implications for hospital finances, right? So you're going to take 5 years of what was a commercially insured member and turn them into a Medicare member, which means you're going from 200 or 250% or 300% of Medicare to Medicare rates for a reasonable chunk of someone's adult life. That is going to have huge implications. Excuse me. I'm not sure. Like, do I buy that he wants that? Absolutely. I don't believe you can accomplish that with an executive order, which requires legislation. If the Senate stays Republican, we won't be talking about this for 2 years. And then we'll see how the midterms go. Midterms tend not to be friendly toward the Republican or the president's party in most years. So it's, not unreasonable to think that perhaps the gap could widen 2 years from now. So, in a still in a 50-50 Senate with Harris breaking the vote, you have to keep every single Democrat, some of whom may not feel that goes far enough as well. Progressives may not like 60. They may think of a public option as a better thing, or, who knows? So lots of unknowns in it. I think the one certainty is any lowering of the age threshold is going to be pretty financially difficult for providers.
Yeah. And you're giving these talks to health system leaders across the country right now, and our audience is usually marketers. So the question may become, okay, what should they do with this? I guess one of the things I think of very immediately when in that particular topic is, how are you prioritizing your engagement and personalizing your engagement of audiences? A lot of times health system marketers, they kind of think in a monolith of commercially insured.
Sure.
Or they may even think specialty care for people 65 and over to make sure they come in for surgeries. But in some of these scenarios that may be down the road, you're now thinking 60, 55, how are we going to engage them, and what is our strategy for that so that we are a source for them? Because their needs at 55, very different than 67 or 69 when they're age into Medicare. And the competition is coming. It's very different with new models and other companies, whether it's people like ReviveHealth or Oak Street, who can dedicate a lot of single-minded resources to a population, or even if it's people like health systems like Geisinger, integrated systems that have clinics just for them. What do you think about that, and any additional things that I guess marketers should be thinking about in the totality of what we've just discussed?
Yeah, I mean, I think your comment on sort of the default is monolithic is the place you have to start, right? The default should not be monolithic. The default should be highly segmented, and not just highly segmented by age and gender and geography, but highly segmented even by the type of commercial health plan coverage you have. That, Blue Cross may be better for the hospital for orthopedic, United might be better for cancer. Who knows what it is? That's really where the tie between marketing and the hospital's relationships with health plans and contracts with health plans meet, right? That margin can vary widely in the same service line for different payers that are paying that. So I think that segmentation, to your point, I really do think that the call to action for providers is to think more and more upstream. I think that we've been talking about this sort of top of the funnel thing for a long time, And where we are seeing tremendous new competition is at that top of the funnel, whether that's CVS or Humana rolling out clinics or Walmart or Optum or whoever you want. The top of the funnel may not be high dollar services, but it has tremendous influence on where those patients go for all of their other services, for pharmacy, for lab, for diagnostic imaging, for elective procedures, all the stuff that we actually make money on as hospitals. So whether we're thinking about the hospital or our clinics or physician enterprise, being a lot better at engaging consumers and employers at the top of the funnel for what the care they want, where they want it, how they want it is the key. Telehealth's not going to solve the world's problems, but it helps. But there are a lot of interesting things being done now on curbside delivery of service, drive-through delivery of service, stuff that most hospitals would have just never considered pre-COVID, that now are, they are considering and are seeing a really good consumer reaction to.
Yeah, so we've been doing a lot of research across the country, and of course looking at other data. The thing that stands out to me is most consumers, while maybe this isn't news to any of us in healthcare, but it always hurts a little when you hear it firsthand, and story after story after story, is that they know that they're paying a premium price for what they consider substandard product. And maybe we could get away with that, not that we were trying to, but it's flipping because of insurance companies and other companies coming in with money and resources and financial models that frankly help them do something better than we've been able to do so far. And that's please the customer and make things more convenient. You referenced curbside clinics, and you and I have talked about it, so I think it'd be great to tell our audience a little bit more about that example, and maybe we can talk about what we can take away from COVID and how we can operate differently.
Yeah, and I'll offer one just very tangible example. Gives me an opportunity to brag on a friend too, so that's always nice. Russ Cox, who's the CEO of Norton Healthcare in Louisville, Kentucky, has done an amazing job guiding the organization to be more consumer and patient-centric, right? I think no matter how we all feel about the business we're in, the healthcare system, and hospitals in particular, have been constructed around the physician, right? It's maximizing the physician's time. It's minimizing their inconvenience, if you will. I mean, the very notion that we have waiting rooms is sort of insulting to people on the face of it. Like I make appointments for things. I expect to go up and go into my appointment. I don't expect to go to a room to wait for you to catch up because you've overbooked yourself all day. That's just those kinds of things that, and I know why we do it. I'm not ignoring the financial reality, but it has been a difficult experience for a lot of consumers. COVID has forced us to deal with a lot of that, right? That you can't sit people in a waiting room. You have to have them wait in their cars, and you have to do this. You have to actually treat them much, much more closely to the way they'd like to be treated. But what they've done at Norton, and I'll just offer an example, you can find some great information online, is really looking at ways of delivering curbside and drive-through service. I'll use the Jiffy Lube analogy, which can be a bit of a tortured analogy in healthcare, but the idea that offering quick service to people for something that they really need to do removes barriers, removes obstacles.
Right.
And there isn't any reason that you can't do vaccines curbside or drive-through. There isn't any reason that you can't do a lot of things in that way. And yet, is that convenient for the caregiver? Not particularly. Do you want to be standing curbside in January or July? Not really. But if it's the difference between people getting care they need, if it's the difference between their kid being immunized for the measles or whatever it is, that's important. And meeting people where they are with care they need. And so, again, you can find this online, but Norton's done a really interesting job of thinking about access differently. It's sort of in between a clinic and a pure virtual visit where there's virtual tie-ins, but there's also these really great alternative sites of care that offer really great access. And I think it's CEOs like that and marketers like that that really help meet the consumer where they are and deliver a better product, right? You nailed it. Hospitals are too expensive for the service we provide, not the quality of care, for the service we provide. And meeting people where they are is a huge part of that. And it's not one thing. I don't want people to believe that. It's not an app. It's not a whatever. but scheduling online, being able to access things digitally, being able to access real care with a person in safer, more convenient ways with fewer touches, right? Fewer COVID transmission opportunities, if you will. Like those are all good things. And those are things that the marketers should have a great deal of influence over and involvement in as well.
Yeah, I just think it's a wonderful example of true consumer-centric marketing and design. I think most of our listeners have probably been in healthcare for a while. And 12, 13 years ago, the phrase was consumer-driven healthcare, which was just a way to say consumers spend more time, effort, educating yourself and figuring out how to navigate a terrible system. And often that was something that the health plans would push. But I will say that I don't know that the healthcare provider side did a lot to help in that regard. But what we have now is health plans figuring out, as you pointed out earlier when we were talking about the Michigan Blues example, they can pick at the top of the funnel in ways that they want to because they know they can offer a better alternative, but do it in a way that serves their bigger goals of driving and steering consumers. So if you're a marketer right now, we spent the year talking about the gospel of growth before COVID. Mm-hmm. We talked about the 4 Ps and getting at the table. Marketers, if you're looking at 2021 and saying, what are my goals for the year? There's got to be, to me, a plan for the next 6 months that you are aggressively pushing that address some of these near-term risks and things that are very, very important. But there's also got to be a plan for the next 5 to 10 years. And that means you've got to get with your operations leaders, your system leader, your clinical leaders and say, we have to make this consumer centric. Look at what is happening and look what consumers want. They not only what they want, what they know. They don't trust us. They know it's a system not built for us there. In focus groups, we heard people say, I don't feel respected or listened to by my doctor, and I blame the doctor, but I also blame the system because the system is forcing him to see me in 7 minutes. That's not necessarily her fault that she can't see me in 7 minutes. They're blaming everybody else. So let's talk about the phrase of the podcast, which is going to be Ooda Loop.
Oh, I get to talk about Ooda Loop. I'm so excited. Yeah.
On that note, tell us about Ooda Loop and how health system marketers can use the Ooda Loop going into 2021.
Yeah, so Ooda Loop, just for a really quick background, was developed by, I think, an Air Force colonel after the Korean War. He was commissioned or tasked with coming up with methodologies that could reduce the losses, the aircraft losses and pilot losses that we'd experienced in the Korean War. And he coined this term, the Ooda Loop. And Ooda Loop is observe, orient, decide, and act, OODA, right? And so actually this is directly relevant to marketers, right? Observe, orient, decide, and act is something I think that we have to do in a much tighter loop, a much faster loop, if you will, to adjust for this no normal period that we're in now, and will have to continue to happen as that no normal window evolves. So what does that mean, right? I will hear a lot from clients, from C-suite executives. We're not worried about CVS. We're not worried about Walmart. We're not in the same business. They're not our competitors. And I say, well, it depends on what you mean by your competitors and in which sector. Like, of course they are. If people are consuming certain kinds of healthcare services and they're now going to buy it from somebody other than you, that's a competitor. If it's a health plan, it's a very direct competitor with a very different set of priorities and a very different agenda and a very different set of financial goals as well. So I think for marketers right now, that Ooda Loop really is saying, let's forget about whatever we knew or thought we knew before. Let's be very data-driven in our marketing. Let's be highly segmented and personalized in our marketing. And let's pay an awful lot of attention to what's happening at that top of the funnel. Because right now, what we're hearing from people and what we're seeing in the data is that people are not accessing services in any way, shape, or form the way they were before, including the ED, by the way.
Right.
When you start hearing about hospitals laying off ED physicians or furloughing ED physicians, or the big ED groups furloughing doctors, Can we think of that ever in our lives that has happened? Like there's no precipitating event like that ever that's
Right.
occurred. We've always had a hard time meeting the volume, but DOAs coming on ambulances are way higher because people are putting off care for heart attacks and strokes. They're not getting the preventative care they were before. Even if you don't care about the money, you have to care about the people. You have to care about people that are not getting that care. And so that OODA loop, that observe, orient, decide, act, is not just about COVID. It's about the resulting behavior change we see from people as a result of the disruption of kind of all of our patterns, right? As humans, we don't go to the movies anymore. We don't go to theaters. We don't travel. We don't do all of these kinds of things, right? So OODA Loop's just a good little handle for it. It's also really fun to say OODA Loop. But there's incredible applicability to marketers because we tend to get locked into these plans. And it's like, here's our plan for the year. It's like, God, right now, I'm really happy if I've got a clear plan for this week and next week.
Right.
And that feels like about as far as any reasonable person can see, right? We can think about contingencies and options, but that's certainly how we run our business this year. And I think how quicker moving, more agile hospitals are thinking that way and shifting gears, again, to meet consumers where they are.
And that's what we have to do. We've got to find ways to meet consumers where they are and learn from it and act on it in ways that don't involve 6-month planning processes with every single leader in your organization to make a decision to start a small pilot program that everybody knows intuitively is better for the consumer.
So 6-month planning to me, it reminds me of this analogy. Years ago, I heard this story that they, and you all may have heard this too, that the Golden Gate Bridge, it never stops being painted. I don't know if you've ever heard this. They start at one end, they paint the whole bridge, and they literally start over because the weather there in particular, and it's metal, constantly has to be treated and painted. And in some ways, I feel a bit like that's planning for hospitals, right? If you take 6 months to do planning, you might as well just keep going because it's what's changed during that period is going to make big chunks of the plan obsolete. So that's not to say be irresponsible. It doesn't mean you don't plan. Of course we plan, but planning quicker, being much more iterative in our decisions, testing concepts instead of sort of beating them to death, which we all do that, right? It's not unique to the hospital side. It happens in lots of industries. It happens in some agencies. It just shouldn't. And so I don't think we can afford to just keep painting the bridge. I think at some point we have to be, that's the OODA loop, right? The act part of it. We've got to get through observe and orient and decide to action quicker so that we can learn from that, observe and orient, decide again in a much, much quicker loop.
It's good. Good place to, I think, end our talk today. And that actually leads into next week. So next week, we're not going to have our normal cadence of the No Normal show. We're going to be hosting 3-part webinar series for you all to showcase 3 predictions for 2021. And definitely make sure you come back and listen to that. We've got 3 specific topics covering things that are really, really critical to you and 2021 and maybe how you use that OODA loop. So Brandon, thank you so much for coming today. It was a good discussion. Really appreciate the time. And hope you have a good rest of week.
Thanks for everybody joining us too. We appreciate it.
Yeah. And for all you out there, please remember, check out our website, thinkrevivehealth.com/COVID-19. There's just a lot of depth and substance on the website from our team, but even more importantly, from your peers and colleagues that are talking about things that certainly you can't get to every week, but certainly will make its way into your world at some point or another. So go check that out, and we'll see you next time. Thanks again, and good luck out there in the No Normal.